Nepal is a bedrock of Himalaya and ceiling of the world. This country is a small piece of land surrounded by two giant Asian power, India and China, which represent a challenge and opportunity for the great people of this nation. But Nepal has another dimension, its medical innovation that overcome the shortage of means by the abundance of creativity and determination to attain excellence. My guest today is Dr. Sanjay Khadgi, I will qualify with the man who leave no stone unbroken. He's the son of this great country, the worldwide leader in minimally invasive kidney stone surgery. He's a consultant urologist at Kathmandu, Nepal. He was trained in minimally invasive surgery at Guangzhou University with Professor Zhang Guohua, who I interviewed
recently.
And he is credited by introducing mini PCNL in Nepal in 2005 and laser surgery for prostate in 2010. He performed more than 7,500 operations of this kind, both in Nepal and abroad, in France, Germany, Morocco, China, Qatar, Kuwait, Pakistan, and he had more than 15 live demonstrations in different parts of India. He's a regular guest and speaker in Challenge of Urology, and he had been visited by several authorities from around the world, including Dr. Arthur Smith, the father of American School of PCNL, and Dr. Sven Lamy from Germany, Dr. Desai from India, and many others from around the world. He's a member of the Nepal Medical Council, and he's a member of the American Urology Association and International Society of Urology, Arab Urologic Association. Dr. Sanjay Khadgi, welcome to British Science. That's a very great achievement. You have a very particular background. You studied in Nepal, in Russia, in China, and conducted many workshops in different parts of the world. That's a great diversity. What this diversity has brought to your personal and to your career, how you become interested in on the urology and especially to stone management?
Well, Jane, there is a long history about how I became interested in this specialized in stone surgery. When I seen Professor Zheng doing mini PCNL in Guangzhou, and then I invited him in Nepal to perform few cases. When I seen his technique, I was 100% sure that I can make revolutionize this technique all over the world. This is by the influence of Professor Zheng.
Zheng is a leader.
Simply, I can say, and I just got mad to do this mini PCNL technique every day and night. Actually, in short, I'm influenced by Professor Zheng from China.
He's a great teacher, yes.
Yes.
Let's talk about the current situation. Nepal, like the rest of the world, has been touched by the pandemic of this COVID-19. And how have you been dealing these days, especially with the patients who are not labeled as COVID-19? Is there any delay in the diagnosis or the treatment of this patient during this current period?
Well, it's a very relevant question in this present scenario. Well, we take all these patients as a COVID positive patient, all the patient.
Yeah.
We do screening all the patient, those who had a travel history and contact with the people. So we just screen them, all the patient, and we do outpatient consultation. And so far, we have a PCR is easily available in Nepal at the moment. So those who are candidate for the surgery, there is no delay in the diagnosis and treatment in our center. though we have COVID-19 patients.
Sanjay, we meet in 2016 at Paris Challenge in Endourology meeting. And later on, 2 months later, I visited your clinic in Kathmandu. And I saw for myself what you are doing. And then the next year, 2017, you came to Agadir in Morocco with Professor Zangohwa. And you conducted a workshop in mini PCNL. You were an advocate for mini PCNL rather than standard technique. Why? First question. Do you think we can achieve the same results with the mini PCNL as the standard, or even better?
Yes. I would say, if you see the mini PCNL data these days, there were somewhere around 200 new papers on mini PCNL technique. But there are so many variations in mini PCNL technique. Different people are doing differently. If you compare mini PCNL and conventional PCNL, even mini PCNL can do better than conventional PCNL. For this, one must see how we perform mini PCNL. As you have seen mini PCNL technique, I'm sure you would say no conventional PCNL
Anymore.
Right? So one must see this technique, how we perform mini PCNL. We get the best result in the world. Several papers we have published on mini PCNL technique. Why mini PCNL? I would say.
Yeah, that's the question. Yeah.
If you see the conventional PCNL and mini PCNL with the mini PCNL technique, there is no boundaries of stone size limitations. You can even remove the larger burden of stone. You do not need, laser is not must. You can even use the simple pneumatic lithoclast.
That's why I will ask you this question later. Yeah.
Okay. Okay.
So you can achieve complete clearance with this technique, with the mini PCNL. More than 90% at least of cases.
Yes.
And what about multiple access to the pelvic shield system? You try to limit the number, or you do? There is no limit actually to the number of puncture you can do to achieve complete clearance if need be.
So in whether you do mini PCNL or conventional PCNL, puncture is the key point. How you make your access, how you make your puncture. That is the key point. So the biggest advantage of mini PCNL is high maneuverability, which minimizes multiple access.
So it
minimizes multiple access, but whenever needed, we can make a multiple punctures. Yeah, and we should not hesitate to do multiple punctures.
If need be, yes. So you do your access using fluoroscopy. Why? And what about ultrasound? Have you ever considered to do puncture under ultrasound, or every time you do under fluoroscopy?
Very nice question. Many people are coming with the ultrasound technology to do puncture, but in my personal experience, if you do the contrast study and with the fluoroscopy, you can see the every detailed anatomy of pelvic calyceal system, how the infundibular length, its width. You can choose the appropriate Calyx.
Yeah.
So you get the complete clear anatomy of pelvic calyceal system in fluoroscopy. This picture you cannot get in ultrasound.
At least
I agree. I agree that X-ray fluoroscopy has some radiation, but we can minimize it. There are certain tips and tricks for that.
What will you do for minimizing the X-ray in your case? Do you use a screen, or what kind of technique do you use?
What we do is we do not use the continuous fluoroscopy view.
Yeah.
One
shot. Yeah.
Just one shot at a time. First, just align the needle with the desired calyx, one shot. Then advance the needle to the desired calyx about 5 centimeters. You do not need to open the fluoroscopy. You just advance the needle, then again one shot. It's a very minimum.
Yeah, step by step.
Use the step by step.
Yeah.
So I have seen in many conferences, in workshop, many surgeons, they use a continuous flow of fluoroscopy. This should be avoided.
Absolutely.
And we have used, most of the time we use the dosimetry, and every year we check how much dose, though it's a cumulative, but it does not exceed beyond its maximum limit. So it is safe.
Stay within the normal. Yeah. So there's now come the question of laser or pneumatic. I know they prefer pneumatic. Why?
Number one, pneumatic. If you buy in Nepal or Asian countries, this pneumatic lithoclast cost hardly 2,000 US dollar.
Yeah, the price is the first issue.
If you buy the laser machine just for stone, it's not less than
20 times. At least.
Cost is major factor, number one. Number two, stone disintegration with the pneumatic is much more faster than laser.
Yeah.
These are 2 points. These are the subcontinent where we live today. Our all people and all patients cannot afford for this all laser treatment. Once you use the laser, definitely the price to the patient will be much higher.
Yes. Sure.
We have to consider this price to the patient.
Not even considering the use of both ultrasound and pneumatic combined, like the Swiss lithoclast and this. You never use this. Use only pure pneumatic.
Yes. The only case I prefer to use laser is when there is a very hard stone with the thin out renal parenchyma. In such situation, laser works excellent. In such situation, when you use pneumatic lithoclast, there is a high chance of perforation of the calyceal system. I have a certain guideline when to use this laser or pneumatic lithoclast.
Great. One thing I have saw as well is your experience with mini PCNL under spinal anesthesia. That's a unique experience. Is it just a matter because your patient are a little bit stoic and can tolerate a long procedure under the spinal, or it is feasible, reproducible, and can be done anywhere in the world?
It can be done anywhere in the world.
So you have to convince.
We must convince. The first thing, people have to see how we perform mini PCNL under spinal anesthesia, though staghorn stone, no matter. What are the advantages of doing spinal anesthesia? Let me tell you. One is it's completely painless procedure even after the completion of the treatment. Number one. Number two, it's a very cost effective. In our center for spinal anesthesia, it hardly costs somewhere around 60 to 70 US dollar.
Wow, that's very, very cheap compared to other countries. Yeah.
But if you go with the general anesthesia, this patient will spend somewhere around $200 US.
Yeah, that's
So
fair amount.
this is number 2 advantage. Number 3, when you perform under spinal anesthesia, patient is half awake.
Yeah.
We can help the patient to turn, and patient can move their head by themselves. So you can protect the neck. Sometimes we never know. If we are not careful, this patient may have a cervical injury.
Yeah.
When you perform this patient in prone position, when you're turning the patient from supine to prone position.
Yeah.
So these are certain conditions and points we have to take in consideration to do mini PCNL.
Under spinal, yes. Concerning the position, you always do prone. So what's your argument for that? Only prone position.
Yes, I have done several cases in supine also.
Yeah.
It's not completely supine. Many papers, many people, they assume that if you do in prone, you consume a lot of time. But in our center, when we perform in prone position, it hardly takes 50 seconds to turn in
the
prone
patient.
position.
Yeah. That's not time consuming.
It hardly takes, so it's not time consuming. So you have to have a good teamwork. And prone is in my personal experience, prone is the position for the mini PCNL or PCNL.
That's the classical way to go.
That's a classical way. But what I'm not happy in supine position is when you use fluoroscopy, in simple stones, you can do it easily. But in multiple stones, because of the spine behind and this vertebral column, sometimes you cannot differentiate. You cannot see the complete stone clearance in multiple stones, spatially. The biggest advantage in supine is for the anesthesiologist. Number 2, it is easier for patient to be in that position. Especially, these are advantages for the obese patient and those who have a cardiopulmonary disease.
Yeah. Great. We'll watch a video and see. Let's see your procedure.
Please.
Sanjay, you prefer to use the puncture of the middle calyx. So why? Tell us why. Why you prefer the mid calyx?
So whenever I talk about middle calyx puncture, many people are surprised. There are certain advantages. Number one, when we go through the middle calyx, it forms the shortest distance from skin to the kidney. That is the shortest distance. Number two. When we are able to make a shortest distance, then stone evacuation is much faster. That is number one. Number two, when we go through the middle calyx, it acts as a neutral position. And we can swing our telescope, even in a mild hydronephrotic kidney, up in the superior calyx, down in the lower calyx, and even it forms a straight alignment from middle calyx to upper part of the ureter. So even for the upper ureteric stone, we can easily tackle these upper ureteric stones by the mini PCNL technique.
So I see.
And another advantage is when we go to middle calyx, the ureteric catheter and our axis forms a straight alignment. We evacuate the stone with the irrigation and also by the retrograde saline push by the assistant from below.
So you are advocate of dealing with the upper ureteric stone, complex ureteric stone, so mostly impacted stone through mini PCNL rather than through conventional ureteroscopy or RIRS.
Why mini PCNL? In our center, even for the impacted stone, it doesn't matter. For 20 to 30 millimeter stone, I prefer to do mini PCNL because it gives you more than 90 to 95% stone clearance on table.
I'm talking about the ureter, upper ureteric stone. You prefer to go through the calyx rather than going through the ureter sometimes. So this is one of your preference sometimes.
Yes, that's what I'm going to tell you. Because when we go from above, stone evacuation is much faster rather than ureteroscopy. We can remove these all stones and give it to the patient complete stones. If you do URS from impacted stone, you just fragment them into multiple stones and you cannot give it to the patient.
Yeah, great. So that's a very great advantage. Yes, we will watch this video how you explore the whole pelvic ileal system with your mini nephroscope through mid calyx puncture. So let's watch this.
Sure.
Sanjay, you tell us about the rate and the nature of the complication, if there is any complication. What kind of complication you have, and what's the rate of it? Have you ever resort, for example, to embolization or open surgery to address this complication, if any?
So far, we have performed 7,500 mini PCNL. I had to do around 15 cases of embolization. 15 cases. That is very minimum.
Minimal, it's negligible.
If you see the CROSS data published in 2012, if you compare my data in mini PCNL, our overall complication rate is about 7%. if you see this data from cross, is overall complication rate is somewhere around 25%. Out of 7% complication rate in my data, about 5% complication fall in Clavin Dindo 1 and 2.
Yeah.
Only 1 to 2% of the cases, they fall in Clavin Dindo 3 and 4. So which is the general and major complication is about, you can say, 1 to 2% in mini PCNL technique.
It's very acceptable.
That is my data. Yeah.
Great. And what is the most prevalent stone in Nepal? See, have you ever done any study on that?
Yeah. We do not have clear data, but in Asian perspective, like India, Nepal, Pakistan, the prevalence of stone is somewhere around 12 to 15%. 12 to 15%. Especially even in Nepal, we have a certain places, especially in the western part, where you visited in Dangari. If you remember, we have a certain places. These are the stone belt areas, where even the family members, every family has 2 or 3 persons were diagnosed with the renal stone disease. These were the stone belt areas, farmost place of Nepal.
And what's the kind of stone you have, the most prevalent one?
Yes, it's about 80% of the cases.
Oxalate or
calcium oxalate, monohydrate.
Yeah, which is the most
80%
hardest stone.
of the cases, all hard stones. And about only 20%, and you can get this 10% uric acid and some 10% non-calcium stones. Most of them are calcium oxalates.
Do you recommend systematic metabolic workup for this patient with stone? And do you advise any dietary change for your patient?
No. What we do in our protocol, if the patient has a recurrence of stone, only then we go for the metabolic evaluation. Only those patients who have a recurrence of stone. Though we perform metabolic evaluation, 80% of these cases, they found to have a normal metabolism. So, dietary factors, these are 10 to 15%, but many people are concerned about the diet. So we advise them according to decrease the calcium load and oxalate load. So we just advise take a plenty of plain water. That is very good for the patient who are suffering from renal stone. And we do give some dietary advices to these patients.
Sanjay, during my visit to Nepal last time, we talked about setting up a stone management fellowship in Nepal. How far did you go with this project? Is the idea still alive?
It's coming soon.
Yeah, so you're working on it.
It's under construction, and probably we'll start this program after 5 months.
Yeah.
Everything on process. So we are starting this fellowship program. My aim is to give the training to our new urologists, to make them good access. That is my first aim, because the most difficult part in PCNL is the achieve access.
Share access, yes.
So we give it. My plan is to give them a short-term fellowship. It's not long as 6 months or 1 year, as most of them will be the urologists who are visiting to my center. They just need to see and some hands-on training. And this is on process gene. So within this 5 months,
we'll hear some good news.
yes, definitely.
Are you considering to train foreign medical graduates, foreign urologists coming from other countries to Nepal?
Yes,
Yeah.
from all over the world.
Yeah, great. So there will be no discrimination. Yeah.
No, not at all.
Okay, Sanjay. Sanjay, it's been a great pleasure talking to you, and thanks for sharing your views and insights, and let us know about the success of the story of Nepalese school in dealing with stone, and wishing you a lot of success and your project, and going ahead with your project of training both urologists from Nepal and from outside the world. Thank you very much. That's very kind
Thank
of
you,
you.
Jin. Yeah, thank you very much for this interview. And this is because of you, it is possible.
Thank you.
And I wish you all the best. And I welcome you to Nepal also. So you
Certainly,
should make the second trip to Nepal.
we had a good
Our
experience. So
institute is
certainly we will be episode 2
yes.
for you as well, and to Morocco.
Thank you very
Okay,
much,
so
Jin.
take care. Okay,
Bye-bye.
see you. Bye
Bye-bye.
bye.